Right. So thanks so much, Paul and Dimitri, for being here. And basically, just wanted to introduce myself. Unfortunately, my other team members can't be here. My name is Jarrett Casanidi. I'm a capacity building coordinator at the AETC NCHCMC. Henry Pacheco. Dr. Henry Pacheco is joining us remotely. He'll be leading the clinical part of the assessment interview in the second hour. And Henry, would you like to say hi?
Hi, how are you? I just stepped out, so I didn't get the introduction from Harvard Street neighborhood, but when it comes my turn, I'll just briefly ask to see who's there.
Great.
Briefly, because there are two of us here right now, and this is myself, Dimitri Petion, along with Paul Dreyfus.
All right, Mr. Dreyfus and Mr. Petion, great.
And we also have performance improvement coaches from the Primary Care Development Corporation on. Sarah and Adele, would you like to introduce yourselves?
Sure. My name is Adele Pereira. I am a senior program manager here at the Primary Care Development Corporation. And as Jared mentioned, we will be working with you on the performance improvement goals and measures that we will be discussing in this.
We're looking forward to it.
Great.
And hi, good afternoon. This is Sarah Bless, project manager at PCDC. Nice to meet you all.
Well, great. Thanks so much. And just wanted to review the purpose of the assessment interview call. We want to then ask you to tell us a little bit more about why you applied and what you hope to get out of this project. We're going to switch today the clinical assessment review with the performance improvement review. So the performance improvement review will come first, and we are hoping to have Dr. Achebe on for that discussion. And then we'll have a little question and answer period, and then we'll go right into next steps. So the purpose of the call is really to have a conversation with you regarding where you're at in your clinic, where you hope to go, and it's also to get to know you and also to allow you to get to know us. So in lieu of an on-site visit, this is the next best thing. Great. So Paul and Dimitri, maybe you guys can tell us a little bit about, whoops, the slide is not accurate there. Maybe you could tell us a little bit about Harvard Street, give us a little background about you, why you applied, and what you hope to achieve.
Well, we're going to split this into two parts. I'll do the blurb about Harvard Street, and Paul will jump on once I'm done to talk about why we're applying. Harvard Street itself is a 43-year-old organization. We were founded in the 60s when a group of nurses from the old Boston Public Health Commission identified that there was disparity in terms of baby vaccinations for babies who were from this community as well as babies who were from more affluent communities in Boston. So those ladies got together, they rented a trailer and started a vaccination program for the community. And that trailer evolved into a full-fledged clinic. Today, we see about 53,000 patients visit a year. We see, we have services in pediatric, family medicine, OBGYN. We offer mental health services. We have full psychiatry services on board, which is something that's lacking in most community health centers. With that said, I'll let Paul talk about the application.
Sure. Harvard Street has been actively screening for HIV and other STDs for years, and you know, we have our adult medicine practice has its own kind of predictive model that it uses to focus in on individuals who might be considered to be more at risk. And our practice with HIV has been to refer patients to the ARV clinic at Boston Medical Center, which is with which we have an affiliation and geographic proximity. But our model with primary care is to really try to bring a much closer alignment between primary care and specialty services for all kinds of populations. And we would like to do that with the HIV population as well, where people have traditionally seen the center as their source for primary care would continue with that relationship, and that we would become much more involved in providing the specialty care, or have much more of a continuum with the outside specialty services. And this is something that we are working on, across a number of different specialties to evaluate service by service, whether to bring the specialty into the building or just to create more of a continuum type of relationship.
I think one other thing that we have discovered with main practice is the fact that whenever we refer our patients out for services, there are times when it's difficult for the patients to get to that end service. So there's a big push for us to really bring a lot of things back in-house. And for example, if we refer somebody outside for something as simple as an ultrasound, they may never go because they have to take 2 buses to get to the hospital for them to do the ultrasound. So those kind of services we brought back into the building. We feel the same is true for treatment for other chronic ailments. And we think that we can improve the quality of care that's being provided to the patient as a whole by making sure that the patient receives the bulk of his treatment under the same roof.
Great.
Great. Thank you.
Jared, the Harbor Street physician medical director hasn't showed up yet, right? Not quite yet?
No, he is with us right now.
Oh, great.
Hi.
Welcome, Dr. Achebe.
Is that Jarrett?
Yes.
Hi.
Great.
Yeah,
Great to have
I had an emergency.
Okay. Yeah. No, we understand. There's always a lot to be done. So thank you for joining us. And Paul and Dimitri gave us a good background on Harvard Street, and we are going to switch around the performance improvement assessment with the clinical assessment. So we're going to do the performance improvement assessment first in the first hour. And I'm going to ask my colleagues, Sarah and Adele, to lead us through that. We're going to, let's see, bring up here on the screen, you should be able to see the assessment that you submitted, and we're going to go right down to the performance improvement section and start there, and then we're going to go to the clinical. So let's see, Sarah and Adele, I'm going to give you presenter privileges now, and you can take it away.
Oh, thanks, Jared. Thank you. I think we do have the privilege right now, so it's loading. But in the meantime, I do want to say thank you to the team at Harvard Street for taking the time to fill out the assessment in its entirety and give us a glimpse into your health center. I want to assure you that doing the performance improvement piece to be the piece that will enhance what you hope to do, in terms of your clinical goals, and adding on things that you mentioned about integrating your services with your site that you refer your patients to into your main practice. I'm sure there's a lot of clinical measures and things like that you want to do. We hope the performance improvement side will help you enhance some of those things. So I'm going to quickly go through a few of the sections in the performance improvement assessment, and then Sarah's going to take over after that. And Sarah, if I missed out on anything, please join and jump in as I go through these.
Okay, will do. Thanks, Adele.
So in the revenue maximization, I actually have to applaud you. I see that your numbers show that you have a 0% rejected healthcare claims, the total healthcare claims. That's amazing.
I'm not sure it's 0%, but it's very low.
Okay, because I'm looking at the number 0, and that looks great. So has that been something that you've been working on, and now the numbers have considerably reduced over time?
I'm sorry.
Has it been something that you've been working on to reduce the percentage, or has that been something that just happened from day one, that you just had great collection rates and reimbursement rates, or did you have to work on this to get the number to 0 or close?
We had to work on the reimbursement situation, and we have gone through a lot of re-engineering of our billing folks with our billing department to improve a lot of those numbers.
Okay, great. So do you feel you are in a happy, comfortable place with this, or do you feel like you would like to do some more goals around maximizing your revenue?
Thank you for advancing the slides. We are looking to, as a community health center, money's always tight, so one thing that we always look at is how do we ensure that we at least get paid for the services that we're rendering, which means looking at the window as number of days in the cycle and also numbers in terms of how quickly are we billing for our services, et cetera.
Okay. So that's something that you feel that your billing team and people that would be involved in would benefit from, and you would like to get from this particular piece of the project?
I oversee that team, so by virtue of me being involved, in anything that we're doing within the context of the project, okay, to improve that area, they would receive that. They would be involved.
Great. Overall, in terms of billing for HIV-specific areas, has there been areas you've already been working on? Do you feel?
No, that's something that we would need to. We certainly would welcome assistance from you guys in terms of maximizing that area.
Sure.
So whatever service we provide, we like to sit down with the expert to figure out how we can maximize the service.
Sure. Great. Great. I do believe in question 23, and I know it's probably going to be too long to answer that now, but do you think that you feel, it says we ask for a process to ensure that you're coding it to maximize. You've said yes, but haven't described the process. I just want to clarify, you do feel you're maximizing it right now to the best you can?
We're talking about question 23, correct?
Yes, yes. I was wondering, you said yes, you do maximize your reimbursement. There wasn't any process described under, but I just felt like I need to ask you whether you feel comfortable with what you're doing right now.
We feel very comfortable with what we're doing with our current encounters. If we add a new class of encounters, we're going to want to do our homework to make sure we continue to maximize reimbursement for that encounter.
So it's basically more for the new services that you would add in. You probably need some additional processes to be.
Yes. Any new service that we added, we would focus around the encounters and also streamlining and maximizing the reimbursement rate for those encounters.
That's really a very clear goal, so I like that. I'm going to make notes of all of this. I feel comfortable with where we have in terms of goals for this. Is there anything you want to add on to this before I move to the next topic?
No, I'm good.
Okay.
Yeah, I think we're good.
Okay, great. I am moving on to the next one. So now next we're talking about the quality improvement and different activities that happens at the Harvard Street Neighborhood Center. I do see your goals for improving testing would be to strengthen behavior interviewing competencies of your frontline clinicians to improve risk profiling for HIV and STD testing. So has this goal been something recent, and how did you come about deciding this to be one of the goals you want to be working on? Was there something that went behind? Was there something that led you to believe you wanted this to be done?
I think one of the things that we have had to do in the past year and a half to 2 years, for example, was we had a flux of victims who migrated to the U.S. after the Haiti earthquake. And we spent time that gives an opportunity to train, to retrain some of our providers on dealing with people who have recently faced trauma. And when we thought we had answers to all the questions, we discovered when we went back and we evaluated what we were doing to a series of PDSA cycles that there were room for improvement. So along the same line, we believe that by working with our existing providers and getting them to listen a little bit more carefully and framing their questions appropriately, we can have a greater impact in terms of being able to have an impact on one's behavior. If we can get the clinicians to ask them questions differently, we think we can have a greater impact in identifying folks who are high-risk folks who need some form of behavioral intervention.
And there's also the element of helping our providers to kind of understand the differentiation and different approaches to different groups of patients by gender, by age, by other factors.
Right. And in terms of, I know you've already began the initial discussion about saying that you wanted to integrate your services with the off-site services. Do you have a plan in place, or is this something you're trying out, or you're looking for this project to help you to come up with ideas of how you're going to do it in terms of the integration of your primary care with the off-site? Is there something in place already you've been trying out?
There is not really. We want to approach this goal within the context of the HIV learning community.
Okay.
It's not something that's very obviously broken. It's not a kind of thing that where we perceive big problems, but we do definitely see room for improvement in keeping with our kind of broader model of really trying to centralize more services in the building for a number of different reasons that we've already discussed.
Sure. Yeah. Great. Are there any specific, other than these two goals that you've mentioned, is there a QI initiative specifically around HIV that you've been speaking about in the past, or were these the two things that came to mind because as soon as you learned that you were going to be part of this project? Or is there anything in a strategic plan somewhere else that we can pull out from in terms of quality improvement?
From our perspective, one of our big push over the past couple of years have been around various chronic ailments in the community where we had initially identified asthma as a big problem in the community. Did some work around that and continue to do work around that. Diabetes is a big problem. We have some modeling, some TQIs that we did around that. And as we look to start tackling this HIV and STD issues, there are other STDs, STIs that we put some focus around. But I think we're looking to learn from the community at large to say, okay, what are some of the models that are very effective, and how do we adopt those models and bring those back in-house and make those models work for us?
Right. Great.
Also, we do fairly careful kind of utilization review and quality assurance around STI, STD testing, PAP, which relates in some way to the STD testing.
Right.
So we're fairly planful about monitoring our population for potential infection.
Right. So we'll be deriving from some of the other things that have been happening now more specific to the HIV population, but you have things in-house that you're already doing. So that's great. In terms of the staff that are involved in this QI committee, I know you said, I think, is it Mr. Paul, do you chair this particular one?
I don't think we've really talked about, do I chair the QI committee?
Okay.
No,
No.
Dimitri, I believe you chair the QI.
Okay.
Yes.
Oh, you got this. I'm sorry, I may have got the names wrong. So who is part of this team specifically? Do you have some? Do you have a mix of staff just to get an idea of who sits on these?
We have a mix of staffs who are involved in this committee. We have a quality assurance nurse that keeps track of all our matrix. We have some IT folks who are involved because they do some modeling for us. Sure. We have several of our providers, some of the MAs who are also involved, because we try to bring together everyone who's involved in the process and try to see what are some of the issues that we're currently facing and how do we address those issues or potential issues.
Right.
So it's a real broad spectrum representing pretty much, I would say, most of the disciplines in the building.
Right. And I guess having the IT folks helps you guys pull out reports and monitor your progress as you do them, as you
yes.
goals together. That's great. Okay. So other than the two that you've mentioned, do you want me to add any more goals to this particular section? I have your two, one for testing and one for actual improvement of care. Is there anything you'd like us to know or add on as an objective for this initiative?
At this point, I would say no, unless there's something that you feel is blaringly missing that we're overlooking.
I think you've got some. I think the top two seem broader goals. I would like to, over time, the coach that works with you would probably sort of deepen them a little bit and sort of make a little bit more specifics to it. But I see your overall goal is to be able to integrate your services, and then talking about your testing, you wanted to add some competencies to your clinical staff and other staff as required. So we could probably, as we move on, make them a little bit more specific. But for now, I think we're good in my opinion. But if there's anything else, you can always go back and add them to it.
Okay.
Okay, good. So let's move on to the next one. And I heard you actually use the word PDSA, and I'm seeing here you are currently participating in a CHIPRA pediatrics medical home demonstration project. What would you say, describe your experience with it? Are you guys good with it? You like it? Do you find the method effective?
I think it's being very successful for us. We are one of 13 pediatric practices around Massachusetts, and there's a statewide collaborative with quite a bit of technical assistance and information sharing among the practices, and it's helped us really to focus on improvement goals and run through the PDSAs. The PDSA construct is challenging because once you've kind of made a decision that you think you're doing the right thing, you just want to go ahead and implement it. So it's sometimes the challenge is to hold back and go through the PDSA cycles or find a way to phase in so that you don't foreclose your options before you have refined your methodology, et cetera, et cetera. But I think it's been a very successful process for us here, and we have a very strong core team in pediatrics that is implementing the medical home, and I think it's working.
Great. So that's good because someone who can speak to that from internally for the rest of your staff. We would like to use the PDSA model in trying to test out some of the new things that you will be implementing or taking over in this project with us, on the HIV/AIDS project with us. So we have the internal support, and if you can, those people.
And also, PDSAs are not a new construct to us,
right,
because we use PDSAs around clinical issues.
Oh, good.
We use them even in terms of looking at some of the operational construct around the organization, where we do a lot of that modeling to address our concerns. So that's something that we're very comfortable with.
Okay. Great. So that would just be something we wanted to, make sure that the health center understands that, and you seem to be in the forefront with this. So this is great. We could definitely use the same model in some of the goals that you'll be setting for in this project. Is there anything more that you would like to speak in terms of the HIV initiative, in terms of PDSAs? I guess you would look during the project to pick up some specific goals that you would like to test them on. I don't think anything right now comes to mind, or do you have something in mind that you would like to PDSA?
No. Again, we see this as a learning opportunity. We're looking to amend, append, and do take away from what we're doing, add to what we're doing to learn from the process and provide greater services to our patient population.
Great. So we will definitely put one of them to the test. Sarah, am I missing anything? I keep forgetting to ask you.
Oh no, it's fine. No, I think things are being covered just fine.
Okay, great. I am moving on to the next piece, which is cultural competency, and I do believe you mentioned here that your staff demographics reflect your population served. So you do have a diverse population. Do you want to speak a little bit about whom? I think in your application I did see you have a high percentage of African Americans / Hispanic, 20%. And am I missing any populations or anything else?
We're in the middle of the Dorchester section of Boston, so
okay.
The population that we serve consists of large population of immigrants from the Caribbean, Haitians, Jamaicans, Trinidadian. We have Anglo-Irish population that we service. We see a growing Asian population with Vietnamese, Cambodian, and many other groups. So I would say
African, Somalis,
yeah.
East European. I mean, we see them all.
We see pretty much folks from all over the world, in Asia and Eastern Europe. So we're a very diverse workforce. We service a very diverse patient population.
And the fastest growing group will I think essentially are the immigrants from the Caribbean as well as the Hispanic populations as broadly defined, being from Latin America as well as Spanish-speaking areas of the Caribbean. So we have a very diverse group, and it depends on what the service is. The dental services see a lot of Anglo-Irish, East Europeans as well. And so it's OBGYN, there's a very strong African-American presence. So it's a diverse practice.
Great. So speaking of diversity in terms of the different populations, have you encountered or heard of any stigmas associated with living with HIV/AIDS among any specific populations, or any general ones that you could let us know so we can consider them?
Oh yeah, I think that, again, it depends on what demographic you're looking at. One of my concerns is the sense of denial that exists amongst some African American groups, particularly the church-going types. So I think one of the things we'd like to do is work closely with the churches to break down some of those stigmas that exist in that community. I think that in other demographic groups, it's not so much a denial, but there is a sense of a doom, and almost some people have complained about being ostracized from their community.
Right.
So I think that one of the things that we'd like to do in everything really is to be culturally competent about the way we approach care, and not just have one size fits all, because different groups have a different approach and different belief systems.
Right.
And so what we're going to have to do is have a multidisciplinary kind of approach on so many different levels, including outreach and education.
Great, great. We like to hear that. Definitely educating not only your staff, but the patients that you see as they come in or reaching out to your community. Like you mentioned, working with the churches definitely sounds like something we would like to help you with. And I'm making notes of everything you just said. And I'm looking, I'm guessing the word, is it patient satisfaction surveys? It says semi-annual patient under question 31. Is that how you solicit patient feedback?
We survey our patients twice a year to get a sense of how well we're servicing their needs. So that is how we get patients' feedback. We also try to collect feedback from our patients from our website and from other areas in the clinic where we capture their suggestions.
Has the clinic ever participated in any outreach in general for other areas and found any methods that were successful in marketing or not done any? Where are we at?
Good question, sorry.
Have we?
Can you repeat the question,
sure,
please?
Yes, sure. I was wondering if you have previously engaged in any outreach activities for HIV, or even if not HIV, any other services before, so we could learn from your experiences of trying to reach out to the community?
I think one of the things that we do on an annual basis is every year we hold a health fair in the community, and we use the health fair as a vehicle to communicate and educate the community around various ailments that afflicts it. In years past, we've focused on breast cancer and the denial involved in dealing with breast cancer issues. We have dealt with prostate cancer. We've had, about 2 months ago, we had a major event where we draw about 400 people into a room who are all Haitian immigrants, and the focus was on dealing with trauma. So we have had some experience in terms of having major outreaches to the community where we attempt to provide information, convey information, as well as educate around issues that's pertinent for the day.
Great.
And the outreach depends on the level. I mean, there's organized outreach. There's also individual outreach. I mean, a lot of our staff, clinical staff, also they're involved in outreach. We've done some outreach through the radio,
local TV,
visits to local churches. We've done work with surrounding organizations, including the Franklin Park. And so on different levels, we've done outreach within our resources.
Right.
What we're looking for is really something that will help us with the resources expand what we're already doing to really impact the community. So that's really, it's not that we haven't been doing, we've been doing this that's part of our mission, it's part of what we do on a daily basis. But we really need, I think, in order to make the kind of impact, support.
Right. So adding on to things you're already doing and then narrowing it down now to specifics for this particular population. As we know, there's a lot of cultural sensitivity too when you do try to outreach to this population, so you'd want to consider some of those things while you do that. So we would definitely be supporting you in that.
Exactly, and I just want to let you know, we just developed a relationship with a group that is going to be focusing on the mental health needs of the gay, lesbian, bisexual, transgender populations. And I think that's particularly important as we extend and expand our family. And so for me, that's very exciting because it's not just one service. I think we will begin to work with them in a number of different ways.
Great. No, that's definitely a good thing.
Great.
Just to clarify, sorry, just to clarify, so that's a collaboration you're having with a mental health provider that serves the LGBT community, or I heard mental health services. I just wanted to make sure that was the main focus of that organization. Or can you talk more about that?
And also, this is Jarrett. Could you just also let us know who they are?
I'm sorry, we were having a side conference. You want to know a little more about what we're doing?
I want to know, we want to know the name of the organization you're collaborating with and also the scope of their services. So are they primarily a mental health provider, or do they offer other LGBT services?
Dimitri will speak to that.
The organization that we're collaborating with right now is Commonwealth Mental Health Services, Mental Health and Wellness Services. They do work heavily with the gay and lesbian community.
Okay.
This is spanking news. We're excited about that. We've been having talks back and forth for, God knows, several months, but we literally just, I don't think the ink is dry on the lease. So they're going to, we have a building at 895, which is down the road. We have a second building. So they're going to be using our building for those purposes. So I think it's very exciting for us.
Sorry, I missed the name of the organization.
Commonwealth Mental Health and Wellness Services, Inc.
Great, thank you.
Yes. And Jared, I think this is, it's a new initiative, a new group of people. You know, I think what they're trying to do is reach out to the gay, lesbian, bisexual, and transgender populations within the communities that we serve, which, as all of you on this line would be aware, has not been served appropriately for a variety of reasons. And so, for me, I think being at the vanguard of any such program is very important and critical.
Right.
That's great to hear. Thank you.
Okay, I do have, go ahead.
Yes.
I'm sorry, someone was going to say something. Please go ahead.
I said, any other questions on that?
Oh, sure. So I think I've got a good amount of goals around your cultural competency and outreach. Is there anything else you want to add before we move on? Because I do believe we have some really good things that we could work on with you. But there may be something that I missed and you want to let us know. Please do so right now.
Well, I think, you know, for us, I'll tell you that, you know, and take this with a grain of salt, because this is a CEO spin. But, you know, I can tell you that whatever we do, we can do better with guidance and support. I think that's really the bottom line. And we have the will. I don't think our problem is not having the will. I don't think our problem is not having the competency. I don't think our problem is not having the staff. But, well, maybe we need a few more staff. But still, I think where we are at this point is if somebody will support us, then we'll really be able to, you know, fly with it. You know what I'm saying? So I just have to say that.
No, that makes good sense. I mean, that's what we are here for, and we do believe health centers do have all the competencies and the skills. What they really need is a little bit more support, and, you know, their staff's overstretched and stressed out. Just us coming in to help you support some of those things so you can take flight with it, as you mentioned. And I totally hear you on that.
And this is Jared again. That is great to hear. This is your project, and we want to help you devise how it's going to help you. And then also there are a good number of other organizations who you can both share information with and learn from. So we're really excited about having the community meeting and getting all the health centers together.
We are too. So looking forward to it.
Great. So I'm going to move off the cultural competency area and move to the next. And I think, Sarah, you're going to be taking over. So, Jared, do you want to move her to be the panelist?
Or actually, Adele, do you want to just scroll down for me? That'd be great. Thank you.
No, I can do it for you. No problem. No,
I should have done it for you.
No biggie. So the next one is right here. It's recruitment and retention. Go ahead, Sarah.
Right. So we kind of touched on this already with the outreach you've been doing to date with the different kind of diverse communities you serve, and it sounds like here, you know, in terms of people who have been diagnosed with HIV, that, you know, they are kind of immediately referred over to the HIV clinic at Boston Medical Center. Do you maintain any kind of relationship with these clients that are referred over to Boston Medical Center?
Well, it depends. So, you know, I'm going to switch hats now and speak like a clinician.
Yeah.
A lot of the patients that we see, a number of them have HIV, and a number of them are followed at BMC for that specific reason. However, there are other primary care needs we pick up. And so the fact that somebody has HIV doesn't mean that they shouldn't have a physical and everything else, and you know what I'm saying? So
yeah.
We have a number of patients who are going to BMC because of this one specific. In fact, I'm thinking as well, I'm talking about one of my patients. You know, she has a specialist who follows her at BMC for HIV. She sees me for everything else. And so what I just do is make sure, you know, somebody's tracking their viral load, and somebody's you know, look at her CD4 count, make sure she hasn't had any opportunistic infections, and et cetera. The kind of thing that primary care providers do all the time. But then the specialty level, you know, will then be moved to Boston Medical Center. Now, one of the reasons why Dr. Knight, who's our new medical director, is going to be key is that he's a specialist in infectious diseases. And what we're trying to do, and this is one of the reasons why we feel this grant speaks to us in ways that you can't even begin to imagine, is, you know, consider, if you will, this same patient I just talked to you about who has HIV, and I'm seeing her for everything else. I can begin to have Dr. Knight then follow her for the HIV, you know, chronically, without having to refer her out. And so part of our journey has been to, first of all, make sure we recruit the kinds of personnel that can provide the service, and then look for the resources after that, because we really would like to make sure that our patients can benefit. So our hope is to begin to chip away at the numbers, because we have the facility to go into the data bank, Dimitri's area, and kind of harvest the numbers around everyone who has a diagnosis of HIV, who's assigned to Harvard Street, and begin to structure the care around that kind of data. So it's not something that I feel is, you know, I think it's something that is within our reach. We just need that kind of support.
Right, right. Was Dr. Knight recruited specifically because of the expertise in infectious diseases, or was Dr. Knight already on staff and, you know, was...
Oh, he was already, well, Dr. Knight was recruited because he's a superstar. And yeah, I mean, he's not only a specialist in infectious diseases, a specialist in pain management. He Masters in Public Health. He's a fellow of the American Academy. He went to Harvard and Johns Hopkins and everywhere else. He's practiced in literally every underserved sector in this country and also abroad. He has a very impressive CV, and so for us, he is. It's unusual for a community health center to be able to attract someone like that, and I can tell you, it took more than just pleading.
I'd like to hear more about that later.
Very excited. Kind of person is here, and we just want the patients to be able to benefit from his expertise.
Great. So in terms of recruitment, I mean, there's many different ways of looking at recruitment. One of them can be from, you know, recruiting from outside the practice and, you know, into the external community, and the other way is recruiting internally, your patient population inside. Can you just talk me through just really briefly about how patients are approached for screening, for HIV screening currently?
Okay, so most times in clinic, we have the nurse triages the patient that comes in with a particular complaint, and oftentimes the patient, the cluster of symptoms or signs or complaints may trigger the nurse to be concerned about an exposure to an STD. That patient is therefore then sent to one of the primary care providers who's on staff on that particular day. once we do the history and everything else and the physical, one of the things we do ask, as per CDC recommendations, is we do a screen for HIV, so that a number of patients who come in for a particular cluster of symptoms that leads to an STD screen also get an HIV test. And so typically how that has worked over the years. Now, what we'd like to do is expand into population-targeted screenings around particular programs, as opposed to complaints, which is more of a public health kind of outreach that can be tied to education, and then could be also then have these programs feed into the specialists that we now have for long-term care. So I think that's where we're.
This is Dr. Pacheco. I'm sorry to interfere in the call. I just want a little clarification. Is that all right?
Sure. Go ahead.
All righty. So the way I understand your HIV screening, let's see, could I summarize it by saying it's risk-based because you first identify the risk, and secondly, could I say it's also opt-in? In other words, the patient is asked whether he would consent to an HIV test?
Correct. We also, there's one other category that I think we should also bring up. Internally, one of the things that the providers have done is to have internal education around screenings, particularly HIV screens. And so around physical exams, for instance, apart from the risk-based testing that comes with the presentation, we also offer that as a public health screen around your physical. And so we very strongly encourage our patients to have that done. Now, it's offered, but we do not have, as you know, doctor, we cannot force a patient to have that test. And so once they agree, of course, we go through the educational process. They sign a form. That form is attached to the lab paperwork, and then they get tested.
I see. Thank you.
Okay. So currently, I mean, in general, do you find that this is doing what you want it to do? Does this protocol, does this kind of structure for your clinical process for testing, is it something that is working for you? Is there any area of improvement that you'd like to work on?
Well, as you well know, one of the biggest, the latest studies that show the increases in HIV prevalence and incidence as well have been African American males. So that's one area that I'm really concerned about. And I think that one of the things we need to do is to have a scientific basis of public health outreach. In other words, to understand where the risks are, understand the populations that are greatest at risk, and to begin to have a coherent plan that targets in a sensitive manner, culturally competent manner, those same populations, outreaching to them in a way that brings them in for not only testing, because I don't want everything to be around testing. Education is almost as powerful as testing sometimes, but we want the educational component. We want I was talking to Jared about this. We want the educational component. We want the clinical component. We want nutritional. We want to have mental health as part of this. It has to be the holistic approach as far as I'm concerned. That's why I'm interested in doing it. So that's where we're coming at this. I think there's improvement around impact, okay? So to answer your question, we have these internal structures that have been there for years. We're talking now impact. Let's go after the populations that are at risk. We know who they are. Let's do it in a competent way. Let's do it in a culturally competent, sensitive manner. But we need the resources, the outreach people. And like I said, we're already building, before this grant, we were reaching out to different groups and developing alliances. Okay?
Yep. I'm writing all this down. Thank you. And I guess my follow-up question to that was, currently, I mean, I know that you mentioned to Adele that you've been doing these, really large-scale kind of community outreach activities. What does your outreach and education staff look like? How do they generally function in the community on a day-to-day basis?
Around the outreach staff, we have one individual, for example, whose responsibility it is to go around to some of the local housing projects and provide health education information to folks who are living in those housing projects. Other type of outreach that we do is we've had providers in the clinic go out on local cable TV, local radio to discuss specific issues around health that the community may be concerned with. We spent a lot of time in February talking about breast cancer and having our providers go out on Spanish radio, on Haitian radio, to talk about the importance of mammography once women reach certain age, to ensure that they are getting those tests done. We've done the same thing around PSAs. You may be aware of, because we service a large ethnic population, getting a digital rectal exam done is not something that goes over very well with a significant number of the population that we serve, where that exam is perceived as something that is completely abnormal and completely unnecessary, and you have the machismo factor within some of those male population, where we try to reach out on an annual basis in Hispanic radio, Hispanic TV. We reach out to other Caribbean groups just to talk about the importance of PSA and the importance of the digital rectal exam and why they need to get it done. So we tend to, again, as a community health center, we tend to have to make the most with the staff that we currently have. So that means that people have to take on different hats. Our providers have been willing to be educators and go out into the community, and we have other staff that have received trainings who have been willing to go out into the community, in addition to what I would call the one community person that we have on staff.
Yeah, let me just put a little development perspective on that. One of our development goals for the next 12 months is to identify some funding so that we can have a dedicated full-time or close to full-time community health education and outreach coordinator, so that we can build on all these individual efforts that we've been involved in and create more of a kind of sustainable infrastructure for community outreach and community education, which fits into what Dr. Achebe was saying about the importance of addressing the people in the community who've yet to be engaged, yet to be served, because we know that we're the people who are engaged, we're serving them pretty well, but that there's just a very large cohort in the community that has not yet been engaged. So that's something where we really want to increase our focus and apply some additional resources.
Okay, great. I hope that funding comes through. Sounds like you have, some amazing, some amazing things already in place that would really benefit from someone who can really put all of their attention there. So thank you. Adele, anything else you want to ask before I move on to access and appointments?
No, good to move on.
Okay, yep. So I know we're at 3:07. When should our section finish, Jarrett, so you all can get your clinical piece done?
I know we did get started a little bit late, but maybe within 10 minutes. Is that possible?
Yeah, that's fine. That's fine.
Okay.
Okay.
Great.
So now we're moving on to access and appointments. It sounds like appointments are generally available within 24 hours. Do you have open access at your practice currently?
We do.
Okay.
We do allow for walk-in in every session.
So it's true open access. I mean, it's
True open
not
access.
and we have extended hours, so you can walk in at any time.
Great. And how long would you say the wait list is for someone who walks in off the street?
We can get somebody triaged within half an hour and in front of a provider on most days under an hour.
That's great. And so is that relative? Is that kind of the same for a person who has a scheduled appointment? Are they a little bit under that? Is it kind of the same time frame to see a provider?
For a person who has a scheduled appointment, what our time studies have shown is that it takes those people approximately 6 minutes to go through the registration process, and they're in front of a provider within half hour of walking into the building.
Okay, that's great. And it looks like you track these measures. Looks like you're paying attention to these measures on a regular basis, on a weekly basis.
Oh yeah.
And
in a big way.
Right.
We also have a population that's very demanding. So if they're waiting more than half hour for service, I will know about it.
Right. Patient satisfaction, or before they're satisfied. So in this area, it actually sounds as if things are working very well. However, I mean, is there anything that you know that you'd like to put out here that would be an area of improvement that you'd like to work on here?
I think one of the things that we've looked at over the years is the fact that the layout of the physical infrastructure is conducive to one's form of patient flow. Over the years, we've entertained the idea of doing some construction to improve what we're currently doing with our patients, with the patient flow in the building, with the queuing that we're doing around the building, how people are queuing. We've spent a lot of time studying our queues.
Mm-hmm. So that's kind of a long-term goal, is to actually physically change the space so you can be more flexible with how the patients flow?
Change the space or get into a much bigger building.
Got it. Okay. Is that an option in the future to actually move your whole practice?
Well, if we get our hands on some real money, that's always a big option.
Okay, great. All right. So it sounds like in this area, and it's fine. There's certain areas of performance improvement where we really will be, really spending a lot of time and energy, and there's some where you may already be where you need to be. So the last section is reporting and population management. And really in this section, it seemed as if you were pretty much doing everything you need to do. In terms of being able to validate your reports, in terms of being able to see your reports on a regular basis, in terms of having a, menu of reports that you look at and review, the ability to do cohort reporting where you can look at a specific subset of patients over a specific period of time to figure out how, what impact you have on cohorts. Looks like you're using registries for your HIV patients. So, in a sense, you were kind of, it was hard for me to see anything that, that perhaps needed additional assistance. So I'm wondering here, is there anything about your reporting and population management structure that, is a sticking point for you, does need further, technical assistance?
Well, I don't think it's so much, everything is resource-based. So we have a staff that's stretched, thin. So I think that's really what this is for us. Mm-hmm. In Boston, Boston has always been, it's not unusual for this city to have, I think every health center in Boston
has EMR and has had EMR for at least 8 years. We've had this for 2002. We've been doing citywide reporting, system-wide reporting, and also we're part of the Boston Health Net network of 13 health centers that does both HRSA reporting and we have the ability to go into our EMR infrastructure, mine the data, do that for everything from chronic disease to shifts in demographics and insurance utilization. So it's not so much that we're not doing anything our peers are not doing in Boston, But what we are saying is, and you can imagine there's kind of a broken record. It's really the resources that we need to do more is where we are at this point. But the capabilities are all here,
right.
and they've been here for years. So it's not particularly unique for Boston.
Right. What kinds of reports? I mean, when your QI committee meets, are you looking at your patient registry? Are you using a panel report to look at data? What reports do you typically look at for your QI process?
I'll give you an example. One of the things that, let's take since you mentioned patient registries, let's take a look at along the line of a diabetic population. One of the things that we look at is, as we look at the cohort, how are we doing as a whole month to month in terms of bringing down
hemoglobin
A1C for that patient, for that population, and also being able to track the cohort and compare and contrast an individual against a cohort. If we had a cohort of 6 that had an A1C above 8, and we're working with them as a group, along the line, a few months into the process, we'll start seeing how the individuals are doing against the group, how the groups are doing as a whole. So there is a lot of analytics around the reportings that we currently do to get a feel of the effectiveness of the programs that we're running for our patients.
Let me also share something that was interesting, because Dimitri and I were in a meeting before yours where a hospital executive was upset at us because our ER utilization had fallen by 22%. And so I was on the other side saying that's exactly what we were supposed to do, is take better care of our patients so they don't go to the emergency room. So that we have data around ER utilization that our nurse quality assurance person tracks. We also track everything from low birth weight infants all the way to patients with malignant hypertension. So data collection and tracking has always been something we've done for years. It's also a requirement for a number of grants that we already have. And we do a lot of UDS reporting. So yeah, we have the capability.
Okay.
We also track screenings and preventive health like PAP and STD tests and mammograms.
So in other words, if we do it, we're currently tracking it.
Great, great. And then maybe what we can do moving forward with this project is just to kind of look specifically at your HIV measures and make sure that what you're doing, you're using all of this data in a way that really relates to the goals of this project with integrating HIV services into your primary care. Okay, so that is basically our section of performance improvement. I think we're definitely at time, so I'll move it over to Jared and Dr. Pacheco, please.
Great. Thank you so much. First of all, I do have a bit of a handicap here. I don't have access to the slides on the screen, but my colleague Jared Casanidi can probably pass the slides for me. Essentially, I will go over 2 things with you folks. One will be I'll go over your assessment, the assessment tool that you filled out, and clear up a couple of questions. I think you've answered a lot of them through the previous question and answer period with PCDC, and then I'll briefly go over the HIV training package, which is online, and you'll eventually have also a printed copy, and there'll be lots of opportunities to go over those. So let me go ahead and start with your community assessment tool. Is the tone, my tone, loud enough, good enough?
Yeah, we can hear you.
Great, great. All righty. Well, first of all, let me ask you a couple of questions. You have 2 delivery sites, but apparently you're focusing your training currently on just one site. Is that right?
Yeah, well, the other side is really reserved for mental health.
Oh, I see.
Yeah, we have a few other, and the reason we separated mental health from the other building is we have the acuity of illness and that's being taken care of by our psychiatrist, Dr. Riley, precludes their sharing one building. Let's just put it that way.
Great. All righty. Now, the site that you're seeking the HIV training for, that's located on your main site in 632 Blue Hills Road?
Correct. So that would be do that. Yep. Mm-hmm.
Now, how far or how close is this center from Boston Medical, where you get most of your HIV treatment for your patients? More or less, how far is it? Do you know?
We're within a 5-mile radius of Boston Medical Center.
2 buses.
All righty.
Yeah.
So
all right. So good bus transportation or metro or something to Boston Medical from your center?
Station, pretty much.
Yeah.
2 bus ride away from between us and BMC.
Great, great. Secondly, you're one of the clinics that has a tremendous advantage of having somebody like Dr. Knight, who is a infectious disease specialist. So I assume that Dr. Knight, although he's an infectious disease specialist, he's also an HIV expert. Is that right? Is that how I could categorize Dr. Knight?
Well, yeah, I think that this is, let me say this, that it's one of the areas that he's very interested in. So correct.
Great, great. Now, in addition to that, in your care team, you submitted a number of clinicians, both nurse practitioners and physicians who are in a pediatric service. Does that mean that you're also interested in pediatric HIV?
Absolutely. There are two cohorts we'll be looking at. We'll be looking at infants who may have had exposure and tracking those, and as well as young tweens and adolescents who are probably coming into their own in terms of their own sexual development and sexual behavior. So we thought that pediatrics had to be part of this in a strong way.
All right. Now, the second cohort, you said young, and they didn't catch what was said under young.
So infants who may have been exposed in terms of vertical transmission.
Right. One was infants exposed, and the second one?
Would be tweens, TWEENS. So people who are in teenage years but are not quite there. So we want to catch them early and begin to have that conversation about sexual behavior and screenings, etc. So those are the two populations. You do also realize that we have one of the highest concentration in terms of using statistical models about burden of disease as well as prevalence. We do have one of the higher concentrations of teenage pregnancy within this population. So not only are we interested in keeping teenagers who are sexually active and who become pregnant healthy, but also talking about the next generation as well. So
that's right. That's right.
We have to look at those demographics and splice them because they don't all fit into one bucket.
Great.
We know from recent Boston Public Health Commission data that we have a very high incidence of STDs, somewhat high of HIV, and very high of Hep B and C in our service area.
Yes, absolutely. Yeah, and first of all, I should advise that the current curriculum menu that we have for HIV does not directly cover pediatric care, but that's something that we can remedy fairly quickly. So we'll be sure to also cover that. Now, the rest of your group, of course, includes registered nurses and a lot of medical assistants who are working with you. So essentially, all of these folks will form teams and will join on this training. Is that right?
So everything we've done, I think, our expert here is really Paul, but the medical home is something that we're trying to utilize extensively.
Absolutely.
And so what we're going to have within this medical home model, we're going to have teams. A team will be one that has a physician, a medical assistant, nurse that are assigned to that particular team, probably a social worker, caseworker if we had that kind of funding, etc. And then the patients will be placed within various teams under the rubric of a medical home. And I think that's where the medical practices are going, and within our BHN as well as other groups, we're already there here in Massachusetts, and we want to incorporate any new programming, HIV being one of them, into this rubric of a medical home.
Great. Now, one of the things, no, that's excellent because that's the direction it's moving. The other question I had, although I think I more or less understand how you mark this, but in order to be sure where our clinics stand, we had a question where it said that we categorize HIV services in 4 different models. Now, you know, like any model, there's space in between. And you checked off two models. One, the external care, in which case you provide HIV testing, but you do not provide any HIV management. You refer them. That's the external model. But you also check the comprehensive HIV model. Now, to understand a little bit better, you currently have 5 HIV patients. Is that right, more or less?
So I think there's a misunderstanding here. What we're saying, and I think the explanation would clarify this. Where we are right now is the first stage, which is external HIV care. That's what we're doing. I would say actually that we're very much between stage 1 and 2. Where we want to be is a comprehensive HIV care management. And so I think that's where there's a misunderstanding.
I see. So you're pretty much stage 1 and stage 2, and you want to be comprehensive, right? Now, one question, and I'm still rolling around the mechanics. The patients that you have, you do your testing, let's say risk-based testing, and a patient with STD turns out HIV positive. Now, are these patients automatically referred to Boston, or are they taken care of in-house by Dr. Knight? How is that? How is your routine?
So yeah, this is a good question. Let me tell you how different pieces tie into the care.
Please.
So currently, right now, one of the reasons why people are being referred to BMC isn't really all about clinical expertise. It's also about the pharmacy, the ability of the pharmacy to carry HIV medications within in-house. So we are, as we speak, working with a well-known pharmaceutical group called Eaton Apothecary to take over our pharmacy. Now, for years, our pharmacy has been run without the capability of carrying HIV medications. Now, with this patient, with Eaton Apothecary, we're currently working with, and we anticipate maybe the end of the fiscal year, which is July, as a takeoff date. We're hoping to not only expand the kinds of medicines we carry to include HIV, but all the high-level psychotropic medications to also provide better care for mental health patients. So clearly, as you know, we're a 340B licensed health center pharmacy. And so what we're trying to do as we expand our services is also expand the capability of the clinic to provide the kinds of pharmaceutical support services that are needed for better care. So even if Dr. Knight were to make all the best possible clinical judgment and care and goals and objectives and treatment plans, he will still, as of right now, have to send them to BMC Pharmacy to pick up their meds, to BMC Clinic to get further pharmaceutical care. So as part of my role is to provide the clinicians with the support services that they need to better take care of patients. And so one of my efforts is this new pharmacy initiative so that we can carry HIV drugs. Does that help?
Yes, it does help. Now, in terms of labs, for example, you can do everything, CD4 counts, viral loads, and all those
Our
other
lab
things.
is run by the University of Massachusetts labs, world-class lab. They do everything. So
great.
There we have no problem.
Now,
I think
let me ask you. Go ahead.
Sorry. Go ahead.
I'm sorry. This is like a. Go ahead. I'm sorry.
So UMass is in New England. After Quest, I think they're probably the second largest lab group, and they have a reference lab that's located literally 2 miles away from our center. So our turnaround time for stat labs is within 2 to 3 hours, which is as good as you get even in a hospital. And they do literally every lab that you need. So they have the capability of doing all the HIV pertinent tests.
Great. Now, let me go back to the patients that get referred to Boston Medical. Do you, let's suppose a patient is sent and he's been seen over there by an HIV specialist. Do you have, and I think you do, but let me see if you do you have immediately access to their medical records, and do these patients come back to your clinic for all other primary care, even though he or she is still taken care of by the BMC HIV physicians? In other words, do you have this, let's say, joint management of the patient and good electronic health record communication between BMC and your site?
Same. I was telling you about the Boston HealthNet group. The Boston HealthNet group is, the mothership is Boston Medical Center, and then there are 13 health centers that are the baby ships, and we're one of the baby ships. Now, we're all integrated into the same EMR system, and so from our computers in our clinics, we have access to Boston Medical Center records. And in fact, one of the things we do during the triage process, I'll give you an example. When I'm in clinic and a patient has been seen in a clinic, the medical assistant that works with me goes into the EMR, accesses Boston Medical Center records, and literally cuts and pastes the specialist's comments so that when I'm in clinic, I already know what the visit was like and what the specialist said. So it's a seamless system that we're part of, and we're hoping to. We're also part of many initiatives whereby they're trying to now not only go beyond the EMR, but also tie in the practice management system so that there's a cohesive, system-wide, uniform, instrument that we're using. So we're pretty much advanced. And Dimitri, this is his area.
I think we mentioned earlier that if a patient comes in and they scratch themselves and we record it somewhere, we can run reports against that and catalog that. Dr. Achebe alluded to the BHN. If that patient went into any other BHN facility from my EMR, I can look up that patient and pull out the visit notes that they may have had from any other facility, any medication that they may have received from that other facility, any allergy, etc. So from a technology standpoint, we are highly integrated, and we leverage technology extensively from an EMR, HIT perspective to exchange information with some of the surrounding other health service providers in the area.
Within HIPAA laws, of course.
Right. Now, just a quick question also. Suppose you're a physician who is seeing a patient for just any primary care visit, and, they observe, he or she observes that, there might be something there with side effects of HIV medications or some abnormal liver functions or something that gives him an idea that he should consult with an HIV expert. This is a patient that's HIV positive and it's already it's already on meds and has been seen in the Boston Medical Group. Does that clinician in your center would that clinician get in touch with the clinician at the Boston Medical Group, or would they tend to call on Dr. Knight for, just a brief consultation as to, what to do in this case? What's the consultation channel?
Well, right now, what they will do is go back to BMC. And so what we're trying to shift, the shift needs to be back to Knight. And there are many ways that we can correspond with specialists. Not only giving them a call, but we can go back into the EMR and send them a flag. And also we can also send email. So we have an integrated system of being able to communicate with, in fact, I just got an email from BMC saying that I have too many red flags. I need to read my red flags. So what they do is not only do they send it, but they also make sure you're reading them.
That's right. Excellent, excellent. Very good. Now, back to the mechanics, and pretty soon I'll review the training plan. But I wanted to ask you, once we, the training plan has both an online or features that clinicians are supposed to follow, and as I said, I will go in detail on them. Online resources, things that they have to follow didactically, and there's also after that there will be a mentorship strategy also to finally get the clinicians to be to move them up from one level to another. As far as the time dedication that you think you might be able to dedicate to this effort, you said that you would probably be able to dedicate 2 or 3 hours per week. Is that pretty much, is that the way it stands? You probably would have a group session lasting about 2 or 3 hours per week, every week, or once a month? How would you say that?
Are we talking about the primary team, or are we talking about the line clinical teams as well?
Well, I was thinking about the teams that you were thinking of putting together for this effort, to be trained for this effort.
I think that would be a lot. Our clinical teams are very, very busy. We have one for our pediatric medical home. We have 1 to 1.5 hours of meeting time per week, and we do a lot of other work on the medical home. But in terms of everybody being available at the same time to go through our checklist and plan our next steps, we try to keep that to an hour a week, and that works pretty well.
So more realistically, it would be about an hour a week.
People show up for that.
Okay, all right. And once we go over the training plan, and especially once you come here during once you're here, during the community meeting and go over, develop your training plans, that will be a little bit more clear as to how much dedication and how you will do this. You said that you might encounter some barriers in your training plan, and you mentioned funding, case management, social work, cultural linguistics. When you mean barriers in funding, you mean that, what did you mean by that?
I think pretty much what we're talking about at this point is that we would like to add more resources to the task at hand. Mm-hmm. The current restriction on adding more resources is funding. So with more funding, we can engage more resources that can provide more case management, more social workers, hire and retain more folks who are linguistically and culturally competent to interact with the patient population. Again, going back to what I opened the session with by saying we're a community health center, so we always tend to be very resource poor. So our people have to wear many different hats, and given the opportunity, we would like to make more resources available. And quite frankly, the only way to do so is by identifying more funding that we can leverage to hire and retain these additional resources to perform the task.
Very good. Thank you so much. Now, Jared, can we go over the HIV training package with the clinicians?
Yes, absolutely. And I am switching to that slide deck. Dr. Achebe, you should see on your screen now a picture saying HIV training package.
And so we'll start with the overview. So I can just go ahead, right, Jared?
Yes, yep, you're all set.
Great. So let me just go over a little bit of the over the training package, and although it may seem a bit complicated, I think once you get into it, and once after you get here, you'll be able to get it.
If they could mute it, there's a telephone that's ringing on your end. I think it's stopped.
I hear that too. I'm not sure. I'm not sure if it's my phone. I don't think so, but
no, and I don't have anything on here on this line.
I will try to hang up and call back because that is distracting.
I don't know if folks can hear it.
That stopped it, or what?
We're still hearing it.
Okay, let's move on because of time.
Right. All righty. Yeah, let me go ahead and try this then. All right, about the training package, I'm in the overview. And what I wanted to mention is that essentially I'll go over the roles and responsibilities of the primary care learning leader, in which case I believe is Dr. Knight. I'll go over a little bit about what we mean by the community care continuum, both the stages and the models, the stage of integration and models of HIV service, and briefly over the HIV training package, which covers, of course, the objectives and approach to our training. As far as the roles and responsibilities, the ATC and CMHC will have the following roles. We'll provide guidance, of course, around developing the learning and the training program. But in the process, we will also evaluate both the site as a whole and also the individual clinicians through assessment tools. These evaluations will allow us to understand better the level of services that you will need, and it will also give you, the clinician learning leader at the site an idea of where his or her clinicians are in terms of HIV. We'll also provide assistance in developing the training plan that fits best your goals and the timeline and time availability that you have. In terms of live clinician-to-clinician training mentorship, we have various methodologies. We have our own clinician mentors who are expert HIV clinicians consultants that can assist us in this process with you folks, and we also work with the national network of AIDS education and training centers that have expert clinicians that can enhance the learning experience of your clinicians. Let me move on to the roles and responsibilities. The clinical learning leader, that's the clinician inside, in your site, I think that'll be Dr. Knight, who will be in charge of essentially the learning experience of the clinicians in the center. That individual, the clinical learning leader, will serve as a liaison between the health center, you folks, and the staff here at the ATC. Most likely, you'll be working very closely with our health team, and that's Steven Perez and Mona and myself, and also with the training managers who will facilitate any problems that you may have along the lines. The clinical learning leader will also oversee the clinical training plans with assistance of our team to be sure that everything is clearly defined for each one of the clinicians. The learning leader will also define a schedule for training in conjunction with the leadership of your clinic. Of course, many times you have to make sure that the CEO is on board and everybody's on board to make sure that you have that time that you have dedicated to this process. And of course, you can always communicate with NCHC staff around the specific trainings. As far as the roles and responsibilities of the members of the care team, those would be the folks, the clinicians that will be participating in the training. We, of course, expect them to participate in clinical training opportunities that are offered. There are specific time commitments. Their time commitment would be for group training sessions, of course, to be determined by you folks, and you just mentioned that you may have about an hour available for that. But the individual clinicians are also expected to do some individual training on their own. We have tremendous web-based resources that we expect clinicians to take full advantage of so that they can better be participants in the group training and lastly, be better prepared when they're having their mentorship, clinician-to-clinician training to ready themselves to be, of course, providers of HIV clinical services. The members of the CLARE team also progress their own learning and through the training package. So this will be, we'll discuss that in another slide that's coming up. And of course, they also complete evaluations as needed. What do we call when we talk about the community care continuum? And essentially, the way we look at it is as framework for integrating HIV care into primary care. And we essentially have two systems of looking at how HIV is served. One is the clinical stage of HIV care, and the second is the integration model. In the clinical stages, we kind of classify community health centers based on the level of care provided to their patients living with HIV. An integration model, then that's where we classify the method by which they provide care. You'll see it more clearly in the next slide, which describes the clinical stages. These clinical stages, of course, refer to the skills and knowledge and experience of the individual clinician. So here we're looking at the individual clinician. We think that a clinician that has, let's say, minimal or no knowledge of HIV or minimal exposure to HIV would be at the foundation stage. These clinicians may perhaps be able to provide HIV testing, and but no medical management whatsoever of HIV positive patients. Then comes stage 1, stage 2, stage 3. In stage 1, you have on-site management, but there's basic on-site management, clinical management of the HIV patient. In stage 2, the clinician is much more advanced. Not only does he provide basic HIV management, but he also moves on to a second line of therapy and deals with opportunistic infections, advanced HIV disease. Those, by the way, will be much more clear once you get into the training package that's online at this point. And of course, stage 3 is a much more advanced clinician. This clinician can manage complex HIV patients and can be involved in third line or salvage therapy and manage complex opportunistic infections and comorbidities. And that's, let's say the maximum level at which the clinician moves, and at that point, that clinician is, an expert HIV clinician. Now, if we look at the clinic, now we're no longer looking at the clinic, but actually at the clinician, we're looking at the clinic, at the facilities. We've broken them into 4 categories: external HIV care, collaborative, supported, and comprehensive. The external HIV care is the clinic, the center that provides HIV testing, but they don't do any management. They refer all HIV patients. The collaborative, in that situation, they do HIV testing. They provide primary care to their patients, but they have extensive collaboration consultation with an HIV specialist. They're practically co-managed by a HIV specialist. In a supportive care, here the HIV care is provided by the primary care physician, and there is, occasional phone support with a clinical mentor as needed, occasional consultation as needed, and that phone consultation can lead to a full-blown consultation in case things have gotten, just a bit more difficult. And of course, the comprehensive, that's where the clinician is a primary care provider that has full capacity to care for practically all situations that come about in the care of an HIV patient. There's always, the complications when you do need a specialist, but the comprehensive is a person who can manage all of his HIV patients, his or her HIV patients. Now, what's the correlation between these two systems? In some ways, the community care continuum provides us a framework, a stepwise approach, because first things, we need to see have we been able to move a clinician from one stage to the other, and secondly, just as important, how we've been able to move the clinic. For example, in your case, you have a very advanced HIV clinician there, but even though he can provide advanced HIV services, you mentioned that the pharmacy is not totally prepared to support that, and so in many other clinics there's issues with the pharmacy, the lab, and other infrastructure things that need to be improved, so that necessarily one phase doesn't follow the other. But if we look at the next slide where we speak about the correlation of models and stages, There we see, in the external HIV care, it also fits the foundation model. These folks provide HIV testing but no medical care, and it moves stepwise into the collaborative care where the clinician depends, the primary care clinician depends heavily on continuous support of an HIV expert, is just beginning to manage some of the clinical aspects of an HIV patient. And then in supportive care, that clinician is much more confident. He's had a lot of experience under his belt, many months, caring for a good number of HIV patients. And there is still a need for some support, some consultation, but there's already a great deal of management. And third, the best, which is the comprehensive HIV care management, where you have not only expert clinicians, but you also have the clinic that has all the facilities to provide HIV care. And you folks mentioned that you're working with the patient-centered medical home model, which is, having not just a clinician, but a whole team ready to provide services to the HIV patient, but holistic services, good pharmacy, good labs, excellent and referral systems to other support and social service and support centers. So that would be the ideal stage to reach in this stepwise manner. Let me go into the final training package. The training package that you might get a screenshot of it, but later on you'll get to see the whole thing. It's a set of resources and tools that help providers integrate HIV treatment. It moves them towards various stages of HIV care, various what we call competencies, proficiencies, I should say. Through this kind of training package, the clinicians gain the necessary knowledge, first of all, and skills to provide higher level of care, and gradually moves them through various proficiencies. And of course, the success of the clinician depends on the time spent on his or on her own, following this, completing these various resources that you have there. And the training package is tailored for the foundation level, the stage 1 version level clinicians, the provider, the stage 2 provider, but it also includes there's also a package there for the nurses and other clinicians that work with in the clinical HIV team. The objective of the training package is, of course, to provide, once again, resources and methods and to build that knowledge base that is necessary for the clinician so he and she can provide effective and efficient care. A lot of this is, of course, based on distance learning. Our resources are updated, and as you will see later, I'll describe some of those resources. The training approach is assessment-based. In other words, we seek to, first of all, know what stage the clinic is and at what stage the clinicians are. So it's assessment-based. And secondly, it's also self-directed, self-paced. So a very ambitious clinician can go through these proficiencies in a very short period of time. And one, because he or she may already have a good base, and so can, just go through this very quickly, or simply ambitious learner. And it's pretty flexible, it's user-friendly, and of course, because it's online, it's available to them 24 hours, regardless of their schedule. And it's accessed through a secure online source that we call the Virtual Learning Lab. That will also make some hard copies available to you, but the online is very easy to access from any computer. The content is dynamic, is regularly updated. The guidelines are updated regularly, and I should mention, I'm just getting ahead, we also have a lot of additional resources. Many of these additional resources have CME hours so that the clinician, as they go through these learning resources and build their knowledge base, they can take the challenge of these additional resources, take those CME-based learning opportunities, pass them, and get CME credits with it also. So we have an extensive additional resource.
Credits for the mid-level and NP level providers?
I believe it's mostly for physicians, but there may also be both CMEs for nurses and mid-levels, but it's mostly CME Category 1. And my other clinician colleagues are not here to correct me because they developed the training plan. And but no, it's mostly for. If I'm going to say go out, I would say it's mostly for Category 1 credit CMEs.
Yeah, and Henry, this is Jared, and I think you're right. I think you are.
Mental and encouraging the mid-level and the nursing staff to proactively engage.
Absolutely, we need to do that and be sure that the RNs not only get the learning opportunity but also get the credits, because after all, we all do need credits. So, but the training approach, the training package is designed to provide support for what we call prescribing providers. Those should be the MDs, DOs, nurse practitioners, physician assistants, and the second would be there's also support for the RNs, and also we have for the LPNs, LVNs, and medical assistants. We are working also on other care team members, and that will be developed as we go along. The core resources, as I mentioned, each HIV learning proficiency is supported by these core learning resources. And one of these that we use is the HIV/AIDS guide for HIV/AIDS clinical care, produced by the HIV/AIDS Bureau, the HRSA HAB Bureau. And secondly, there is the guidelines for the use of antiretrovirals, and those are updated for adults and adolescents. The clinical care manual produced by HRSA has been broken down in chapters that support each proficiency, each competency that the clinician is working on. We also have the ANAC, the Association of Nurses of HIV Care core curriculum for nurses. I believe the very last edition is online for their use and as they progress through these proficiencies. Lastly, there's also a NCHCMC webinar series that are live and both archived. We have about, 5-7 archived webinars, and we plan to increase those webinars in numbers. And the webinars cover various aspects of HIV care, all the way from labs, from the basic HIV 101, and so on and so forth. Will, as I said, increase our number of webinars. The supplemental resources are very rich resource that we have there. Each has, once again, proficiency-based resources that also contain things like ATC-based resources, online print materials, including some textbooks, journal articles, case studies, and lots of CME activities, lots of presentations, and job aids and point-of-care resources. And we provide a direct link to a specific page, so the clinician doesn't have to be looking around for it. They just click on it and it gets right to that resource. Just a brief overview, the HIV training package includes the following components. It has a curriculum menu, which has a listing of the proficiencies, and then the core and supplemental learning resources. So at the very left page, if you see it, we have it both in Word and on Excel form. On Excel form, you have the proficiencies, for example, identify and manage metabolic syndrome, manage anemia, prevent and identify and manage lipodystrophy. I'm just thinking of the stage 2 proficiencies. Of course, it starts at the very foundation. And then it has the specific chapters of the HRSA manual and the guidelines that may apply to this. So it has, as I said, the core and supplemental learning and other resources, all of them proficiency-based, so that the clinician can, in an orderly fashion, follow their progress of learning. There are tools to assist the clinical learning leaders to design and implement and also monitor the training plans based on the curriculum. And as I said, we have a monitoring framework for HIV training that the clinician learning leader can use to follow how each one of his clinicians is accessing and is going through these curriculum. The curriculum menus, we personally have available the foundation stage, which would be for those folks, including medical assistants and other social workers, very basic, and then providers at stage 1, part 1 and 2, at stage 2 and at stage 3. We also have for registered nurses, plan 1 and 2, and we have also for licensed practical nurses and medical assistants. The menus, the curriculum menus, they guide the users through all the proficiencies, And as I said, it includes the core supplemental, and it provides essentially a one-stop access to learning resources. So each proficiency is followed by all of these three supporting core resources. And it provides direct link, and as I mentioned, it also provides category 1 CME credits. They are available in two formats, whatever it's easier for you to follow. One is a Word format, and the one is a Excel. The Word format allows you to follow, I don't know if you have the page layout view there in the curriculum menu, but it allows you to follow each proficiency one by one. Proficiency 1, for example, diagnose and manage the core resources available on the supplemental for each proficiency in a Word version. Now, if you'd like to get a bird's eye view of the whole process, you can access it in the Excel version, where you have the proficiency on one side, the curriculum on the other side, and the supplement, the core curriculum and the supplemental. So it allows you to follow it either way. There's also a framework for monitoring. The framework for monitoring essentially is proficiency-based. Once again, it seeks to monitor the progress that the clinician has been making. So, for example, the monitoring framework includes the listing of the proficiency, and it asks whether the HIV learning resources have been introduced, whether they have been viewed and completed by the clinician, whether they have been discussed in a group form, and whether mentorship, if required, has been assigned to each or a grouping of proficiency, and lastly, if the proficiency has been applied in the clinical setting, which is, of course, the ultimate proof of success of this whole learning program. The Virtual Learning Lab is actually a communications and knowledge management tool that you folks will be using as your members of the primary care learning community. Access is restricted for participants to share information, resources, and ideas, and best practices. So it's there to serve you and to be used by the clinicians to communicate with us also. It provides an online home for the new training package, so that, as I said, can be accessed from any computer. And I shouldn't need to go through the supplemental tools, but essentially they are guides from other AIDS education training centers for a National Clinician Consultation Center, something that every clinician should be familiar with. It's a great national resource for those urgencies that show up of the person who has just suffered a stab wound with a contaminated clinic and with a contaminated needle and all this. I think it'd be nice to be familiar with the National Clinician Consultation Center. There are also patient resources, and there's access to the Stanford database, CME activities, and other resources. This is more or less my introduction to the training package. Pretty soon we will send you an assessment form to be filled out by your individual clinicians, and hopefully you will be able to send those back to us. My colleague Jared might be able to explain a bit more on the details, but the assessment is very important because it allows us to know where you are at this starting point, what needs to be reinforced, and at the end of your participation in our project, when we send an evaluation assessment, comparing to this initial assessment, it also will give us an idea what progress has been made. The initial assessment, of course, gives us a little bit of an insight into the demographics of your clinicians. It's always important to know the demographics of clinicians that have been trained. It gives the assessment also allows the clinicians to give us an idea of where they are in these individual proficiencies. For example, given each proficiency, they're allowed to say if they're able to perform this proficiency, if they are able to perform it only under expert guidance, if they're able to perform with consultation, and if they're, are able to perform it independently. So it starts from unable to perform to able to perform, and they can go and check off each proficiency, so that way you know exactly where your clinician is. And it's a very good tool for both us and for the clinician learning leader and you folks to know where this group is headed. I think Jared, have I covered everything that I should have covered in my part? I've tried to whiz through it and catch up a little bit in time.
Yeah, thank you, Henry. That was great. You did get across everything. I know that was a lot. And I have pulled up on the screen here the self-assessment for the provider. We do have self-assessments for each level of clinician. I will be sending those to you shortly after this call. Who should I be sending it to? Paul, is it you, or should I send it to Feliciana?
It should be forwarded to Felicia.
Felicia, okay. Okay, great. And we are hoping to get those back, if possible, before the community meeting. I know that's a tight timeline. That will give us a little bit more insight into the skills and gaps of your clinicians, and will help us have a better community meeting in April.
Jared, also, is it true that it's best if they send it back to us electronically, but if, given the fact that the things in the clinic don't necessarily run in an orderly fashion and not everybody has access to computer, that it can also be done on paper and we would cover any FedEx charges if they collect all of them on paper and send it back to us?
Yes, thank you, Henry. Thank you for reminding me, Henry. Obviously, electronic is best for us, but of course, whatever works for you we can use.
Well,
so I know that
we'll get this turned around, and Felicia will forward the completed PDFs to you via email.
Great. I definitely appreciate that. Thank you so much. So I know that was a lot of information on the clinical side. So do you have any questions related to the clinical training?
Eric, I need to run. My dad's in the ER, so I need to go and see him in Rhode Island.
Is that Dr.
Well,
Nate?
good Lord.
That's me, Dr. Chiba.
Okay, well, thank you very much, and we look forward to meeting you in a couple weeks.
And we wish your dad well, of course.
Thank you. Thank you, everyone.
Thank you very much.
Oh, there's one last piece on our side. Sorry, one last thing from the PCDC side. We're going to be in touch with you in the very near future to set up a time to look through our project plan. So the assessment that we just did with you, we're going to put it into a project plan, and we're going to give you, we're going to send you an email in the next couple of days to set up a time. We're going to try and do that before the community meeting. So that will be an hour-long time to review that project plan.
Could you forward a copy of that project plan to us beforehand so we have an opportunity to look over it prior to meeting with you? Talk about it?
Absolutely. We will give it that to you a few days beforehand.
Okay. Thank
okay.
you.
Great.
That's it.
Thanks, Sarah. And I actually, before we do go into any more questions, I did want to ask if your team there, Dr. Achebe, had been able to make any more travel arrangements. I know that you and Mr. Dreyfus have made your travel plans, but what about Dr. Knight and Mr. Petion?
Mr. Petion, as of this minute, is homeless in D.C. And the determination is this event in D.C. or is this in Maryland?
It's in D.C.
Okay, so the event itself will be in D.C.
Actually, I'm sorry. I believe it's just outside D.C. It's in Virginia, I believe.
Okay, so right over the bridge, or we're really in Virginia?
Well, it's in the metro area. Right.
Right.
Is it Crystal City? Is that correct? Here in Crystal City?
Yeah.
Okay.
Yes.
I have not received confirmation of my hotel arrangements, but I know we discussed it. I did get an email saying that someone was working on it, but I have not received a confirmation. This is Paul.
Right. Okay.
Now, this is who should I be talking to at minimum make the appropriate arrangements, and we would facilitate the financial aspect of it.
for your travel?
Yes.
Since you already have your ticket, we're just gonna reimburse you. So hang on to your itinerary and your boarding passes, and then submit them after the conference.
Okay. So for Dimitri Petion, who should make the hotel arrangement? Is there a contact person for the hotel arrangement?
Yes, actually, you could just let us know. And forgive me, I can't remember. Is he going to stay for both meetings, or is he just staying for the community meeting?
Just the community meeting.
Now, what is both meetings?
We have the community meeting, which is I believe Thursday and Friday, and then we have Synchronicity, which is Health HIV's national meeting on Friday and Saturday.
Okay. Let me follow up with you on that one.
And Dr. Achebe, forgive me again. You're planning on leaving DC on, was it Friday night or Saturday night?
I'm sorry, Dr. Achebe
left the room.
Yeah.
Oh, I'm sorry. I thought that was Dr. Knight. Okay. Still figuring out your voices. Okay, so
Either.
Well, Dr. Knight, I will get in touch with Felicia to send you some more information, and we can.
So you'll take care. We'll communicate the duration of stay to Felicia, and you'll take care of the hotel arrangement.
Yeah, that would be best, I think.
Wonderful. Thank you.
Great. I did want to, before we leave, did want to ask if you have any other questions, anything about the clinical training or the program as a whole.
I think we're all set on this end. We're eager to start the process, and we're looking forward to it.
Great, excellent.
This is Paul. Could I ask you if you could email us this PowerPoint? I went in after the conference call, after the first web conference, to try to access the materials, and I couldn't get through. There were like 3 layers of sign in, and then you had to download a widget, and I couldn't make it work. So if you could just routinely email us the PowerPoints, that would be great, rather than have to deal with all that.
Sure, absolutely. I will do that probably in a couple minutes, right after we get off the phone.
Great.
And in regards to next steps, we are going to assign your health center a coordinator, a clinical coach, and a performance improvement coach, and these three members of the AETC team will help you through the trainings, and will be on site for the community meeting, and we'll get to meet you in a couple of weeks. So thank you so much for all your time, and we are also looking forward to working with you.
Great. Thank you so much. Have a nice day. Thank you.
Take care. Bye-bye.
Bye-bye.
Bye.
Bye-bye.